Hi everyone and welcome to the AHP Leader podcast. And today we are doing a live streamed conversation special in recognition and celebration of World AIDS Day 2020, which is on the 1st of December. So this is the night before. And we're recording this very special discussion with an international MDT AHP panel. And we're going to discuss the importance of the day, what it means to us as clinicians, and the importance of rehabilitation for people living with HIV and AIDS. So I'm delighted to introduce this panel with you today. We're live, so anyone can ask questions. You do need to be signed into YouTube to be able to ask a question on the chat box, or you can ask questions through Twitter as well. Just DM me or post them. I'll be checking all the channels. So I'm going to move to my right and ask Andrew to introduce himself first.
Hello, yes, I'm Andrew. I'm here from a bit of a double whammy. So I'm a paediatric occupational therapist, so I don't currently work in HIV services, but I was diagnosed with HIV around 5 years ago. So I have, lived experience. So I've been asked to come and chat a little bit about that, hopefully.
Thank you. Now moving down to Saul.
Evening, everyone. I'm in Durban, South Africa. I'm a physiotherapist and a lecturer at the University of KwaZulu-Natal. And a lot of my research is around rehabilitation for people living with HIV.
Thank you so much. Coming down to you, Amy.
I am an occupational therapist working in inpatients in Chelsea and Westminster Hospital with patients.
Oh, I think we've just lost Amy maybe. So I'm going to move on to Hellen.
Hi everybody, my name is Hellen Myezwa from Johannesburg, South Africa. I'm a physiotherapist by training and a researcher in HIV and rehabilitation. And most of my work now is predominantly research, but I have extensive experience in clinical and working with people and organizations related to HIV.
Thank you so much. Darren, over to you.
Hello, my name is Darren Brown. I am a cisgendered gay white man of mixed Irish and English heritage. I live in London in the United Kingdom. I'm a physiotherapist and I specialise in HIV disability and rehabilitation, and my primary role is in a clinical capacity. However, I'm an emerging clinical academic.
Thank you, Darren. And last but not least, Mark.
My name's Mark Binette. I'm non-binary. I live in Melbourne, Australia. I'm a physiotherapist working in HIV at the Alfred Hospital in Melbourne. And I run a lot of, community programs for people living with HIV, a lot of exercise therapy, and also cover the acute wards at the hospital.
Thank you so much. And it's extremely early for you, Mark. So we're very grateful for you, in particular for joining us. What is tomorrow morning? So thank you.
I'm actually coming to you from the future. It's World AIDS Day here. So
yes. Thank you so much. So I'm going to start off by asking Darren to give us a quick synopsis of what World AIDS Day is. Now, Darren has just confessed that he actually wrote a blog in 2017. So I'm going to kindly ask him if he'll send us the link and we'll post it on the YouTube channel. So Darren, what does this day mean and why is it important?
Thank you. And I had to actually remind myself, so I'd be very happy to send you the link. It's on Physiopedia. But World AIDS Day was the first ever global health day in 1988, one of the peaks of the AIDS epidemic. And it was created as a response to show compassion and also solidarity for people living with HIV and AIDS and also their caregivers. Now, along with that, the Red Ribbon was created, and the Red Ribbon was created to represent that solidarity, that compassion, and also the determination to fight stigma and marginalization. So the Red Ribbon was actually created by a group of artists called AIDS Vision, and they purposefully made sure that the Red Ribbon was never, what's the word I'm looking for? I can't think of the word, where you copyright something. So that the idea being is that anyone can use it, and it's purposefully designed so it's easy for everyone to just get a piece of ribbon that's red. And the red represents different things. So first of all, it represents a connection to blood, but also to passion. And that passion is not just anger, but also love.
Wow, well, that was very emotive, actually, and very powerful. So thank you, Darren. And we all look forward to reading your blog for more details. So what does World AIDS Day mean to us as clinicians and us as people? Now, Andrew, I'm going to come into you first to help kick us off, and then anyone else that wants to come in.
Yeah, so thanks, Rachel. Obviously, like I said earlier, I've been diagnosed for 5 years now. So I've had, this is going to be my 5th World AIDS Day as someone living with HIV. And because of kind of, negative experiences, I guess, throughout the last 5 years in relation to stigma and prejudice that, not only other people living with HIV and AIDS are facing, but me individually, things like campaigns and projects throughout the year are just so personal and so important on a personal level. This one especially, and I think, looking back at World AIDS Day and kind of the global scope that it has the potential really to kind of break down stigmas on such a large scale. So a lot of my work now as someone living with HIV and someone talking about it quite a lot, quite openly, to reduce stigma, World AIDS Day is kind of special because it has that scale. Even just, looking back on what Darren was saying, kind of the first 2 years of World AIDS Day were, the themes were around children and young people, and they faced lots of backlash because of that. But actually what they were saying was, this is something that's affecting people of all ages, and they did that because they wanted to break stigma. So that's just our aim really every single year, is to kind of have a theme. This year's is global solidarity, shared responsibility, to kind of not only stand in kind of unity towards people living with HIV or people affected by it, but to kind of raise awareness, to get people to talk about it, to make it not taboo, and to, the main outcome is to reduce cases, to reduce new infections. Don't really want to go on too much just personally, but there's specific things that have happened throughout the last 5 years that show me that stigma and prejudice is, and misinformation is still rife, really. Even just the other day, one of my colleagues asked me very nicely that if I was shielding because of COVID-19, and what that did was spark a conversation that, no, I'm undetectable, which I'm sure we'll talk a little bit more about, and therefore not in a high-risk category, so I'm not shielding. And that just shows that actually there's a lot more work to be doing, because she was a healthcare professional, but still didn't know the true facts and kind of everything about it.
And I think, just to add to that, it's not just the misinformation, it's maybe the ignorance of people not taking the time out to learn. There's so much information out there, lived experience, what is fact, what is fiction, but I just don't know as healthcare professionals if we do take the responsibility in ourselves to learn. So I'm really grateful for you all sharing this space on the podcast today to help increase awareness and for people to identify their own learning needs around this. And I just want to say, Andrew, you've done some incredible stuff. So we could share some of the links for the work you've done as well online, for sure. Now, Mark, I'm going to come into you next to say, ask you, what does World AIDS Day mean to you? And why is it important from your perspective on the other side of the world that this is recognised and spoken about?
Yeah, look, I think it's a really great opportunity to look at where we've come in the last 12 months as clinicians, as people living with HIV, and everyone kind of working in this sector to, one, celebrate the achievements of the last 12 months, but two, also as like a reminder, like you said, Andrew, a lot of our colleagues, even in as health professionals, might not be the most up to date with their knowledge around advances in HIV management and treatment. And it's an opportunity really to share some of that information and just make sure that people are staying up to date. There's so many competing things going on for a lot of people in terms of staying on top of professional development and knowing what's going on in other areas. And I know that can be really challenging for people, but I think having a regular point where you're like, hey, do you know that this is what's happening in HIV right now? It's a nice little reminder and a friendly way to kind of communicate that, I think.
Thank you. And Helen, coming into you next.
Thank you very much. I think Andrew and Darren and Mark have touched on really important points about World AIDS Day. But I think I want to underscore the awareness, because the minute you take your foot off the pedal, people think the problem has gone away. And there's been research that shows that if we do not keep awareness up, and we have to do it innovatively because people get tired. And it's quite interesting to watch the COVID pandemic. Yesterday, I was in a queue buying something in the pharmacy, and there was an elderly gentleman, and I absentmindedly went less than a meter. And then I said, oh, I am so sorry. And I jumped back like 2 meters. And he says, oh, don't worry, I'm so over this COVID. And I was stunned, and I thought, well, it's not over us. So it's the same sort of psyche that happens even with HIV. Once it's not in your face anymore, people relax. And I'm always saying, when I speak about the importance of awareness, there are 18-year-olds coming up every day. And we do know that, you know, the pandemic is strongest between 18 and 55. And these are potentially people who can get new infections as they become more sexually active, or they can get infected in many other ways. And so it's so important that we keep our foot on the pedal, and we do it innovatively, and we keep engaging with the people who are around us. And it's everybody. It's not just the young folk. It's everybody around us. And so awareness, World AIDS Day brings back a lot of memories for me. When we started, I remember the very first World AIDS Day, and we were all so excited, but the fear that we met in the community was actually quite palpable. And there were some people that came up to us and asked, but why are you doing this? You don't have to put it in our face. And I thought, ooh, you know, so it's a challenge all the time. And I think that awareness, I think awareness, and more awareness, and awareness at different levels as well. So that's World AIDS Day for me.
Do you know, I'm just having these vivid memories of my childhood as you're speaking there, Helen. Saul, I'm coming into you next, because I was born in the late 70s, and in the 80s when there was a lot of campaigning, and my mum, who was a nurse, was like, don't ever sit on the toilet seat. I just had this vivid flashback, and I was like, why, Mum? And she's like, because you'll catch AIDS. And it was just that whole, around that time, it instilled fear in you. And it was almost like when you were getting to the age of becoming sexually active, it was, you know, wear protection so you don't catch HIV, wear protection so you don't get pregnant. But it wasn't really, it was always about reducing the risk of HIV transmission around that time. And you're right, it's almost like for the children growing up today, is there that level of fear? Is there that level of awareness? Because we now have something that's treatable, if you like, that has the same life expectancy, whereas before you would die of AIDS. So Saul, what are your comments around that, is from a non-expert here?
So my kind of interest in HIV, it was a bit different maybe to a lot of others. You know, I trained to be a physiotherapist actually in England, even though I'm grew up in South Africa. And I certainly never thought I'd end up working, you know, with people with HIV. I returned to South Africa in 2007, and I was looking actually at the various themes of World AIDS Day. And in that year, the theme was leadership. And South Africa, you know, for anyone who knows the history around HIV in Africa, certainly would know we had a real sort of crisis in leadership. And, you know, it was a bad time. You know, I was working in a palliative care facility as the only physiotherapist in a 120 bed facility where people were essentially then just being left to die because they weren't being given treatment. And it, you know, it was around the time where some people were finally starting to get on ARVs. And with rehabilitation, we are seeing, you know, some amazing recoveries, real sort of Lazarus effect. And my whole, you know, I was someone interested in sports and, you know, other things in physiotherapy, and that just changed my life. And you know, 2007, I was looking back, you know, South Africa, we had about 300,000 deaths a year, eh? So almost 1,000 a day. And Helen's absolutely right. We have to keep this message going, because as much as, you know, we want to say, you know, you can live a full life on treatment, and absolutely you can. The reality is in South Africa, we're still losing over 100,000 people a year to HIV. You know, it's the largest cause of death. And people are complacent, and, you know, other things take precedent, COVID and whatever the case may be. And, you know, we've just got to keep sort of pushing this message. And, you know, we have come a long way, but there's still a lot more to do, I suppose, would be my message.
Thank you. Now, Amy, I'm coming to you with a specific question. So Andrew's mentioned a little bit around the stigma that's still associated with HIV and AIDS. And I've mentioned a little bit around our ignorance as healthcare professionals. Do you think there's still a stigma associated amongst healthcare professionals? And if so, why do you think that is? And then the next part of that, which anyone can come into, is, you know, what we're going to do about that.
I think I'm fairly new to the area actually as a healthcare professional, so I've only really worked in it for about 8 months. So I think what was really interesting for me was, like you were saying, the awareness that needs to be spread to healthcare professionals, which might include a stigma about people being actually quite high functioning and maybe thinking there might not be a role for healthcare professionals. So I think that's probably why World AIDS Day is really, really important, is because when I first came into the role of HIV in this specialism, I don't think I had an appreciation for the absolute plethora of difficulties that people can have with HIV, how it can impact on so many different areas of their functioning, so cognition, their neurology, how it can affect their mental health, how it can really, really perforate through their interactions with other people and their ability to socialize with other people, and how AHPs can really help in trying to create interventions to improve their quality of life. So I think for me, I haven't come across a huge amount of stigma, more so maybe misunderstanding or a lack of knowledge in this area. So I think that's maybe why it's really, really important as well.
Thank you. Look, Darren, I'm going to come to you, and then anyone else that wants to jump in. But why is it important that we know, that we educate ourselves as healthcare professionals about HIV? Why is it important?
Well, to start with, because there's 38 million people living with HIV worldwide. So that's a really good reason. But I think also what's really important is a lot of what's been discussed is around some of the really important historical lessons that have been learned, but also an opportunity at World AIDS Day to talk about successes. So, for example, we know that 68% of people worldwide living with HIV can now access antiretroviral therapies. See, these are anti-HIV medicines, and they're now so effective that people can be undetectable, meaning that they're untransmittable, meaning you cannot pass on the virus. And this is such an important message. And I remember when this became really big in 2018 at the International AIDS Conference in Amsterdam. We were both there, weren't we, Mark? And, you know, there was a U=U party, and it's such an important message. And every year since that point for World AIDS Day, it needs to be out there. It needs to be passed on. The message needs to be passed on, because so many people are not aware of this information. And that is part of the armor that we can use to address stigma and discrimination. It's not the only thing, but it's a really important message that when you take medications and you are undetectable, you cannot pass on HIV.
So there's a
Just
comment. Go on, Mark. Go on, come in.
Sorry, I was just going to say, I think that's such a great point, Darren, that like, and I think this relates back to what you were saying as well, Amy, about like stigma and things. As allied health professionals, a lot of the drivers behind stigma are fear and ignorance. And if people are armed better, like you said, Darren, and they know that, you know, with current medications and management, U equals U is a thing, suddenly that can really help to reduce people's anxiety around either contracting HIV or I guess some of their misconceptions about how it can be passed on. And that, I think, has a huge role to play in reducing stigma.
Yeah, and the comment that I was just going to reference that's come through on Twitter was around the concept that normal people don't get HIV. And then when you have certain celebrities come out as having, so if I think this comment in particular is about Gareth Thomas, you know, when he done a documentary series, HIV and Me, I think it was called. And it was actually someone who's saying in the public eye, who's saying, I'm living with HIV, it's undetectable, this is what it means it cannot be passed on during sex, for example. And that really helped this person to conceptualize that actually this is a virus that anybody can get. Does anyone have any comments around that? It's almost, I think it links into Helen's comments about it doesn't happen to someone that I know, it couldn't happen to me, when actually it could. Now, Andrew.
Yeah, I mean, obviously this is one of the biggest parts of my work really is around, at the moment, obviously U equal U since, as you said, Darren, 2018. And I think what we look at, coming back, actually what you mentioned, Rachel, about that installing fear. And it's a really fine line that we need to find, because actually what we see is if we install too much fear, people are so scared that they aren't going to get tested. So then what we see is then an increase in people being diagnosed late. And what we know now, and for people who don't know, watching the podcast, is that, yeah, there's a risk of difficulties along the line. But now if we start treatment as early as possible, like me, I started within 3 months and I was undetectable, and I am living a very, very normal, healthy life. So what we want is to kind of show people with the U equal U campaign that you can live healthily and happy, because then we should hopefully see an increase in people testing, an increase in people being diagnosed early, and therefore an increase in people starting treatment early, so people being well. And then what we see is, obviously, you know, coming back to that link between COVID, installing fear, you know, is there a kind of a difficulty there with people not getting tested because they are petrified? And then obviously we know the knock-on effects of that, of people passing it on. So it's kind of finding that, yeah, balance of installing, you know, not fear, but kind of making people aware of the dangers, but also kind of sharing the truths now, because we don't want people to shy away from coming to health services.
Yeah, and I think there's something about, with topics like this, being able to listen to people have conversations about it, because it's much more personal. Whereas if I think back to maybe around the time you started to learn about HIV, Darren, as a physio, you know, I used to work in infectious diseases and HIV. I'm trying to think of how long that, it was over 10 years ago now, but my learning, there wasn't networks, my learning was out of textbooks, and it was from infectious disease consultants and from HIV consultants, but it was very rigid, and it was very, you know, it was just very factual, there was no humanity to it. So actually these types of discussions, and maybe that's where the documentaries and people speaking about it openly is really powerful, and that can change the conception and the beliefs or misinformation or stereotypes, if you like, about who will get HIV, because that's the other thing, isn't it, the stereotype of the virus itself.
Sorry, just to add to that really quickly, what we saw then, you know, is kind of from the 80s and 90s and kind of streamlining, you know, that it was a gay plague. But actually now what we're seeing is a spike in Black heterosexual men in London who are testing positive at one of the most at-risk groups, and kind of potentially is that an impact of us focusing a lot of our fear towards one community. And I think there's an article, I think from last year in The Guardian, of the designer who created those slogans and the banners, you know, don't die of ignorance, those ones that you mentioned, Rachel, about not sitting on the toilet seat. And he said the reason why they had to do that was because so many young men were dying. And he said they had to install that fear to stop it. But actually what we didn't know was that 20, 30 years down the line to today is that I'm here now talking about stigma that I still face. And then kind of, you know, we think about COVID and kind of, are we following in the similar footsteps that in 20, 30 years, people are still facing that kind of stigma. So it's, yeah, again, it's that fine line. It's really interesting.
I just wanted to say that was a really interesting point you made, Andrew, about aiming fear at one group of people. Because I said I'm still learning about this speciality as a healthcare professional, but I found it really interesting, the statistics about new diagnosis going down by such a huge amount in gay men, which is fantastic, but that it had only gone down by about 4% in 2019 in women. And I do think that's really interesting to think about, is that awareness not only being aimed at certain communities and certain clinics and certain areas of life, and actually something like this, World AIDS Day, is a really good way of kind of getting it across to a more global audience. Yeah.
Thank you. Now, Helen, do you want to come in?
Yes. I just want to speak to the issue that Darren raised regarding being really knowledgeable. And I think, Andrew, you spoke to that as well. In South Africa this year, the theme is about making health choices and healthy choices. And I think we can only make those healthy choices if we are informed, and informed with, I always say, the right knowledge and good knowledge. And I just want to speak to one important aspect I always underscore is having your local knowledge, because the pandemic is not generic and it's not one size fits all. It actually is so different. Even if I take the South African situation, from province to province, it's very different. Its drivers are different. You know, what puts people at risk is different. Access to medicines is different. Access to information is different. And it's so important for us as people who are active and who are interested and who are influential in this area to always point that out and be able to allow people to find out what is actually happening around them. And as I think of the theme this year in South Africa about making healthy choices, it's so important that both as people living with HIV, healthcare professionals, and people who are active in this space, to be able to guide people and say that, you know, there isn't one set of knowledge that they need to know. There are basic facts about HIV, but there are drivers that are so different from geographical space to, and I'm sure if we shared amongst us, we know that they are different in each country and in each region. And I just wanted to say that for people to make healthy choices, and some of those choices include whether they are going to stigmatize others or to be stigmatized, is really dependent on that knowledge that we have. And it's such it's a mind-blowing space, but the information we need is actually quite simple. And sometimes we need to remember to keep the messages simple and to keep the information simple. Thank you.
I love that concept, especially with someone as clever as you, Helen. I've been doing a bit of research about you and all your credentials. So I love that concept. Now, we've touched on the pandemic quite a bit, and I just want to throw the question open there. How has a global pandemic affected HIV awareness, access? And we're going to talk specifically about rehabilitation, but you know, let's start off there. Has there been any impact at all? Is it the same as any other, you know, long-term health condition, or is it different? And it might be different, like you said, Helen, depending on where you are in the world, depending on how your country's been affected by COVID. We've been pretty badly hit here in the UK. So, we might have a different. Saul, can I come into you, please?
Yeah, thanks, Rachel. Are you talking specifically in the context of COVID or just more broadly HIV and rehabilitation?
I think let's stick with broadly, and then
Yeah.
and that could be from a research angle, it could be from awareness, access,
Sure.
getting access.
So this is you're absolutely right to point out Hellen's credentials. So sorry, I'm going to embarrass Hellen here, but when I got interested in this field and then decided to do my PhD in the area, I had to hassle Hellen into supervising me because of her expertise, both in practice and then in academia. But, Hellen's background is in Zimbabwe and I'm in KwaZulu-Natal, which is, you could call the epicenter really of the global HIV pandemic. And, access is such a massive thing. And what we saw, that even if you have a physiotherapist or occupational therapist at a local hospital, people really struggle to get to treatment even once and thereafter. And, we're talking of, our research is showing anywhere up to 50% of people with HIV also have at least one disability. So it's really, really difficult for them to access rehabilitation. So we looked into alternative solutions, which in my case was literally us going into rural communities door to door and treating people in their homes. But this was around sort of 2015, 16, and the stigma in South Africa, as much as we have 8 million people living with HIV, the stigma is still massive. And, we couldn't even mention that we were doing a study into HIV. We sort of had to pass it off as that we're just coming and doing health and exercise, because participants were so worried, they may be sort of outed in the community. And you heard stories of people would travel 20 Ks to another clinic to pick up their treatment rather than go half a kilometer, So the stigma is still there, but Hellen's absolutely right. You have to know what's going on in the location where you're working and adapt your solutions specifically for that. So we found, going into people's homes and working in local communities to be quite beneficial. It's something we still need to sort of build on more, but we've got to be innovative. We've got to, really reach out to everyone because there's so much unseen disability related to HIV. As much as you might be on treatment, might have an undetectable viral load, CD4 count's perfect, but there are lots of visible and invisible disabilities, and that's where we as rehab professionals can really have a great impact.
Thank you. Now, I wonder so with some conditions, to give examples in relation to cancer and other long-term conditions, as we emerge out of this global pandemic, which was still very much in, there is going to be an importance in terms of making sure people get access to treatment, access to screening, access to testing. Is that something that is happening within the world of HIV? Does it need to? Even on a transmission level, you've just got me thinking that we're all in socially distanced. If you start a new relationship, you can't even snog someone because unless they're in the bubble. Is this a public health message that needs to get out? Because we're going to be in a stage that we've never been, all this promiscuity, I can't even say the word, people at university not having freshers weeks and things. Is it a public health message, Darren? And then Mark.
So I think to just briefly touch on the point around maybe implications of COVID-19 pandemic, I think obviously we know that it's impacting all areas of non-COVID adjacent healthcare services. So, every single healthcare service is currently being affected globally, and many people living with either undiagnosed or diagnosed health conditions are being affected. And we see that across many different areas. And there's lots of data in the UK about that. So just an example, late diagnosis of cancer, for example. And we are seeing that also happening in the context of HIV, where people are not coming forward for testing. People are unable to continue to access their pre-exposure prophylaxis, or PrEP, which is a medicine that prevents the acquisition of HIV when taken daily or on demand. And there's been examples of people not being able to get that and then acquiring HIV. People are having sex during pandemic. People are having sex in lockdown. There was a campaign here in London, which was the Zero campaign, which was to try and get zero sexual health, to get full sexual health screening of everyone under first lockdown, so that there could be no onward transmissions, and that would include all sexual health conditions, including HIV. My belief is that I don't believe that was as successful as was hoped. But I think that the implications on rehabilitation are real in the context of HIV as well. And rehabilitation has such a vital role across the full continuum of care for people living with HIV, irrespective of age. And I think that at the moment we are seeing rehabilitation services due to COVID-19 pandemic being disrupted across all different health conditions as well. And that includes HIV, but I'm going to emphasize this. That's doubly compounded because of the lack of HIV services that exist in the context of HIV rehab. Very few exist nationally, European, worldwide. They're very small numbers around the world. And so when they're being disruptive, there's a huge implication on people living with HIV not being able to access the rehabilitation required to optimize health-related quality of life, functioning, and well-being.
Wow, another powerful statement, Darren. Thank you. Mark?
Yeah, I guess I was just going to say that in Melbourne, in terms of our COVID situation here, it's been a pretty rough year. So we've kind of just come out of our second wave. We have spent about 5 months in lockdown, in various lockdowns. The most significant was like you could leave your house to go to exercise for 1 hour a day, but that was about it. You couldn't be more than 5 kilometers from your home. You couldn't visit anyone. You couldn't go to anyone's house. You could basically go to get your groceries and go to a medical appointment, and that was about it. As you can imagine, health services were really, really hugely disrupted during that period. And what I think we saw was, a lot of redeployment, a lot of service shifting towards the acute sector, which was obviously needed during that initial kind of wave. But as that has started to settle down and services are starting to resume, what we haven't seen is that return of services and return of funding to programs that were pre-existing. And I think in the context for HIV and rehab, we had a lot of our clients who weren't keen to come in. Maybe people who were immunocompromised or felt that they were at a particularly high risk were really fearful of going out into public settings, of going to community services, even if it was for legitimate health. Like they would, instead of attending rehab or attending physio or whatever kind of therapies they would normally do, there was a lot of fear and a lot of people avoiding that. And I think we're starting to see the kind of flow-on effects of that, where people are presenting deconditioned, people that were previously really fit. They were going, for two walks, 5Ks plus every day. And over the course of this year, they've just lost so much of their independence. They've lost so much of their strength. They've lost so much of their social contacts with other people. And to me, that's been hard, like seeing a client come in that I haven't seen for 8 months and seeing how much their life has changed from not just from COVID, but the restrictions around COVID, the fear around COVID, and the lack of services that have really been able to be delivered during the pandemic. So I think, I know that everyone's kind of situation in different countries is really, really different, but as things start to move forward and, maybe there's vaccines and stuff on the horizon, we do need to really be aware of, where our attention is being held and what steps do we need to do to make sure that we're not losing focus of like some of the big things that a lot of us here have dedicated our careers to.
Absolutely. And Mark, I think that's probably translatable across the world, what you've said there, actually. I think lots of similarities for sure. Now, Hellen, I'm going to direct this question to you, but for the next 15 minutes or so, we're going to focus on the importance of rehabilitation, particularly from a therapy perspective. So for those listeners that just don't know the impact of physiotherapy, occupational therapy, all the therapies for people living with HIV, do you want to start off by just giving us a quick review of why therapy is important?
Thank you very much, Rachel. I think there are about, I think everybody on this panel can contribute to this, but let me get the ball rolling and say, and let me get the ball rolling from maybe a personal perspective. So as part of my career, I kind of, was interfacing with HIV on the clinical platform. And at that time, as one of my colleagues said, people would think HIV equals death. And of course, then people didn't know what role rehabilitation professionals had. And I think we didn't know what role we had as well. And we didn't locate what we would have to do in terms of HIV. And thus began my interest in HIV to say, how do we frame this? And so some of the first studies that we did were to really study the epidemiology, which is what kind of difficulties do people have? And we framed this around a concept called the International Classification of Function, which is the ICF. And it basically makes it easy for us to define the different problems at what we call impairment level, which is really at the level of saying what is wrong with my muscle, what is wrong with my nerves, what is wrong with my headspace, and so on. And then how does that impact the way I act and the way I do my activities, and what sort of disability does it give? Just to give a sort of simplified version of that description. And from that, we did several studies, and some of them have been continued by many people on this call. And it really showed, as Saul said earlier, just how many problems people who were living with HIV were experiencing. And some of them were impacting their daily function and their daily quality of life. And so we were able to name them and count them and place them into a way that everybody can say, okay, there's a lot of pain out there, for example, there's a lot of muscle weakness, there's a lot of difficulty with, just walking to your nearest shops, and breathlessness. And, I remember one of my first studies surprised me how many, I think there were 90% of the people that I tested who said that they had a lot of ringing in their ears and actually had discomfort because of that. And, this has improved now over the years because the drugs have become much better, but this was a side effect, for instance, of TB drugs. And while, a person, it's not visible, but it really does impact a person's quality of life. Another simple example, I did studies among sort of an ordinary population and tested muscle strength, but then tested muscle strength in a group of mine workers who were these butch guys with really, ripple, abdomen muscles. But they had such weak hip flexors that I could literally just with my finger resist them, and they couldn't push up against that. And those are things that you wouldn't know unless you tested. And with the inclusion of rehabilitation into their health trajectory in how they manage the disease, apart from taking their drugs and looking after their nutrition, if they made the health choices of what exercises to do, what rehabilitation intervention to do, that improves their quality of life. And without that knowledge, we were not sure what we needed to say or do or contribute to the trajectory of healthcare for people living with HIV. But I think that we have a good body of knowledge now amongst us. I know Darren's recent study has really added to that. Saul's study added to a lot of the service delivery models that we needed to implement. So for rehabilitation, I think that generally we all know that rehabilitation professionals contribute to the quality of life of people with any chronic disease. And now HIV is a chronic disease, but it has its nuances, it has its differences, and we need to understand those differences. I'm a physiotherapist, but I've had to learn what mental health issues are. When I was a student, I ran a mile from my mental health lectures because I fancied myself, as Saul said, as an orthopedic physiotherapist. But I've learned over the years that if I want to make a difference, I need to look at the whole person. And to look at the whole person, you need to work in a transdisciplinary manner, which means sometimes I need to be a bit schizophrenic and be a bit of an OT, maybe a bit of a, so that I can really get to the crux of the matter with the individual patient and the person and treat them as a person holistically. And that has been a great learning curve for me as a physiotherapist. And I'm still learning, and I think I'll continue to learn. So I think I'll stop there and allow others to come in.
No, that's amazing. Now, Darren, I'm going to come to you and Amy just to give us a little flavour of what a day in the life of Darren Brown would be, that effervescent physiotherapist that we all know and love. Why do you love your job so much?
Oh, I'm getting there with the effervescence. I lost it for a little bit, but I'm getting there. coming back.
It's still there. It's still there.
It's still there, isn't it? So I'm really lucky because I get to work with Amy on the daily. So both myself and Amy, we both work at the Chelsea and Westminster Hospital in London in the UK, which as a trust is the largest HIV unit in Europe, serving a population of more than 15,000 people living with HIV. And we deliver a very unique specialist HIV rehabilitation service, which includes inpatient rehabilitation, which is both physio and occupational therapy, and also an outpatient HIV physiotherapy service, which is clinics on a one-to-one basis, and also a group rehabilitation intervention. Now, pre-COVID, that all run really smoothly. However, now we're not running the outpatient service for a number of different reasons. But the day-to-day is we are majority treating inpatients. Now, what's interesting about this is that we are a regional centre, so we do get patients that are referred from other hospitals to us for their inpatient care. And we're also a national HIV malignancy centre. So any complex HIV-associated cancers will also come to us from across the UK. But a lot of what our focus is actually basing on what Hellen's research has taught us so much, making sure that we holistically assess a patient's functioning and let them tell us what they can and can't do and what disability they may or may not be experiencing. So every patient we see has a World Health Organization disability assessment schedule completed, the 12-item questionnaire, which has been used in Hellen's research for measuring prevalence of disability amongst people living with HIV, which is what my research was modeled on, of Hellen's work, using that categorization to identify when people may be experiencing functional limitations as a proxy for disability. We do that. And then from the physio side, if people are experiencing mobility issues, we objectively measure that with gait speed. And then I'll let Amy talk about what we do from a cognitive side, but we try to make sure that every single patient, no matter how they present or what they present with, is given the opportunity to subjectively and objectively have their functioning and disability assessed so we can holistically treat their needs in an inpatient hospital setting?
Yeah, and I wanted to add to that as well. I think it's a really good point that you make about being holistic. And I think Darren's one of the most turquoise mix of physio and occupational therapists I've come across since I've been working in occupational therapy. I think I've learned so much as well from Darren in terms of the unique needs of those living with HIV, in terms of the episodic disability. So I think meeting people, learning about their good days and their bad days, and planning for those bad days. Because one thing I think that's gone across all of the patients that I've met is that they feel like they've lost some control over things and trying to do their daily activities, and that they don't know when it's going to hit them next. And that unpredictability can be really frightening. So I think I've learned how amazing an AHP could be to give them the tools to try and take some ownership over that. So something like breathlessness or fatigue management that I know Hellen was speaking about could really give people some power over those days that they feel that they're really, really struggling. In terms of the cognition that I know Darren was just touching on, we do that HUDAS that he was speaking about to try and see if there's any areas like concentration and attention that people are struggling with. And then we'll do an Addenbrooke's cognitive assessment with those people to try and just get an idea of what areas they might be struggling with most. And then if there is some areas like attention, I think as an occupational therapist, I try and focus rehabilitation on what they like to do and try and work towards getting their attention better to do that. So, for example, if they want to be able to go to the shops and they're at risk because they can't divide their attention, then we work on that. And I think that can really, really give people a good quality of life, even though it doesn't feel like a big thing at the time.
Thanks, Amy. Now I'm going to ask Mark if he's got anything to add before coming into Saul to talk about some of the more service level. Mark.
Oh, anything to add? You put me on the spot. No, go to Saul and come back to me.
So coming into you and just some of the comments that Hellen made about some of your research areas.
So I think it's interesting. I mean, Hellen will attest to this as well. You know, we're in South Africa where we have a very large population of people living with HIV, but I'm sure she's had this question. Anyone who's a physio OT, people ask, but what are you doing working in the field of HIV? You know, surely, how does a physio help? You know, people just think medicine, you know, and, you know, worst, like when you end up in ICU or whatever, but you know, my answer is, you know, where can't we help? The whole body is affected, and amongst the various rehab professionals, we cover all of that, as well as, you know, the very important area of mental health, which the OTs are certainly better trained in, but also bringing in psychologists. But, you know, it's quite a daunting area. So, Rachel, I don't want to speak too long, but I've sent you a few links that maybe you can post. One of which is a very useful tool or resource of Darren's, but also I don't think we have a Canadian in this group, do we? But you know, they've done some great work in HIV rehab, a collective known as Realize, who used to be called Quigger. I think Realize is more catchy, but together with them, we produced a sort of e-module on HIV and rehabilitation that it's more geared towards sub-Saharan Africa, but to be honest with you, you can, you know, anyone who's interested in this area could learn quite a bit from that. And then I've put the link for Realize as well. And just, there's some good resources out there just for people who are new to the area and who want to kind of immerse themselves. And then, yeah, link up with us on Twitter. Darren's a master on social media as well.
He certainly is.
And thanks for all your work, Rachel, as well.
No, honestly, I think it's I mean, I've learned so much on this podcast for sure. So, Andrew, coming into you for your comments, please.
Yeah, I guess obviously looking at it, you know, in the UK, we're very good at kind of putting a lot of money within acute services and what we are learning now, especially in regards to COVID, you know, long COVID, kind of putting resources in community care. And I think, you know, thinking about in relation to HIV, as we move away from this kind of acutely unwell condition to now the majority of people in the UK kind of living with a long-term condition and living well, kind of, you know, we know what comes with that and what comes with long-term health conditions. So we do have some amazing OTs, Amy down there in the UK working in HIV services, but there's still not a lot. And I think, you know, we have charities in East London like Positive East who really are amazing, but we rely on peer support workers who are volunteers, unpaid, with lived experience to work with our most vulnerable and our most complex cases. And this is people living with, as we mentioned, you know, comorbidity, kind of having to manage medications, multiple appointments, drugs and alcohol, employment, finances, poverty, all these difficulties that we know come along with it. Yet in the UK, we're relying on volunteers to work with these people, where actually, you know, we have OTs by trade. Our job is to support people with these issues. So I guess, you know, moving forward, hopefully kind of learning from past mistakes, I guess, in regards to HIV and AIDS, to hopefully kind of put more resources in that long-term care. In relation to COVID, at least, we can kind of hopefully right some of our wrongs. But yeah, I think, you know, going forward, you know, there would never be enough OTs and physios working within these populations, but unfortunately there is still not enough.
So I've got a couple of questions come through. I'm conscious of time and I want to come round to everyone for final comments, lessons learned, signposting to where people can learn more. Mark, I don't know if you've got any comments now or whether I should just go straight to questions.
All I was going to say was, I think even just like the fact that we're all here from around the world on YouTube Live, you know, everyone's sidestepping and innovating and finding new ways to connect with not only with, you know, other health professionals, but with our patients as well. And I think that it's really important that we keep people living with HIV centered in this conversation and allow them to actually kind of guide that process of what is the best way that we can be continuing with services or adapting our services to meet their needs. Because I think, yeah, at the moment there's a lot of talk about what we're going to do next, but it really needs to be appropriate and make sure that it's going to be a good fit for it to be successful.
Thank you. Now, question from Instagram, which I can only imagine is from someone very young / student. So they didn't even realise that HIV physios, let alone OTs, exist. Is it something that's quite common, or is it something that it needs to be a profession in its speciality in its own right? So I suppose that means if you're working in a, you know, big teaching hospital, you might not have a HIV physio. So who wants to come in and answer that to start with? Darren, and then maybe coming into Helen.
Yeah, I was going to say, it really should be Helen. Go on, Helen. This is your remit.
So it's quite an interesting question, and thank you to whoever posted that question. So in South Africa, one of the first studies we did was to look at, you know, what was the interface of physios, OTs, and rehab professionals with people living with HIV. And at that time, with a prevalence rate of 36%, it meant that, you know, your probable patient load, you were unlikely not to meet somebody with HIV. So I think every physio, every OT, every nurse, every speech therapist, every psychologist who is dealing with any chronic disease because of the comorbidities will encounter HIV. So what we've done, just to answer specifically, is that in this region, we've mainstreamed HIV input into most of our curriculum, because it's very unlikely that you will deal with patients. At least 3 out of your 10 patients will probably have HIV. And in many cases, because of the fact that you're dealing with people who are unwell and are in hospital, you will deal with somebody who has HIV. So, you know, as Saul said, as I've said, I'm not sure of my other colleagues' journeys, but many of us realize we don't know what we're doing. So we need to study this area, and we need to make meaningful evidence-based inputs so that we are offering ethically the correct type of intervention. And so as a physiotherapist or any health worker, to me, it's immoral if you don't know something about conditions such as HIV in countries where you are likely to have a fairly high prevalence of the condition. Thank you.
Thank you. And there's a question that's kind of linked to that, but not, from Twitter, in terms of what is the economic impact of this? So are therapists needed in HIV because if they address some of the needs? Darren, I think this is probably in reference to what you were saying. It will reduce the economic burden or impact of HIV. Who wants to come in there?
I'll kick off. I'm sure others will join in. I want to touch on the last question a little bit. So firstly, HIV rehabilitation is not a certified a credential in the context of either physiotherapy or occupational therapy. And I think there's lots that we can learn from other chronic health conditions. So for example, in the United States, the American Physical Therapy Association has created a board certified level of cancer rehabilitation. Now, we know that when it comes to cancer rehabilitation, you're not going to have a specialist cancer rehab professional seeing every person with cancer. There's this kind of hierarchy where the specialists see those with the most complex needs, but at the bottom of that pyramid, every single rehabilitation professional should have the basic skills to treat a person living with and beyond cancer. And I think that in the context of HIV rehabilitation, that's where we need to get to. We're years behind that, but I think that it would be amazing to get to the point to have accredited courses for HIV rehab. We're not there yet, but every rehabilitation professional, for exactly what Hellen said, should have the knowledge and skills to be able to treat people living with HIV, hear and understand their needs and treat them holistically and work with them. So can you remind me of what the question was that you said came from Twitter there? Was it the economic thing?
Yeah, could we reduce the economic burden of HIV if we had more therapists?
So that's a really complex question, right? Because I think that we know that people living with HIV who have access to antiretroviral therapy are living normal life expectancies. And because of that, are living longer and are aging with HIV and are living with multi-morbidity, which is other health conditions on top of HIV. And actually, that's where the cost implications potentially come on top of living with HIV. And rehabilitation professionals are so great at addressing so many of those other comorbidities. And I talk about this a lot as a physio. You know, physios deal with the respiratory complications like COPD, or the neurological complications like a stroke, or the musculoskeletal conditions like lower back pain or osteoarthritis. Well, we know that in the context of HIV, there's higher prevalence of those things. So rehabilitation professionals have a perfect role in that. But then also thinking about physical activity. Big shout out to the World Health Organization this week, because they have just released their global physical activity synthesis of knowledge. And for the first time, they have included a synthesis of physical activity and exercise guidelines in the context of HIV. They've actually classified HIV as a non-communicable disease, in fact, which I think is a huge nod to U equals U. And with that, we know that physical activity interventions improve health outcomes, improve health-related quality of life, and do not have a negative impact on disease progression. So even as a simple intervention, that works. But we know that the evidence suggests that people living with HIV are insufficiently physically active and the most sedentary population of any health population living with a chronic health condition. So rehab professionals are so good at addressing the health-related challenges of overcoming behavior change. And therefore, we have a huge role in that economic value. The research isn't there to prove that we have that economic value. But the common sense says, of course, if we help people live more independent lives, function independently, be more economically active, live the lives they want to live, they might use health services left. So the economic argument is obvious, but needs to be proven.
Darren, you're like a little spokesperson, aren't you? You need to be like up on some kind of international stage or something, like, honestly.
Don't give me a microphone, I don't let it go.
Honestly, well, you have got a special microphone, haven't you?
I just want to add, sorry, Rachel.
Go for it.
In terms of the economic impact, I think the studies around the disability adjusted life years, the DALYs and the QALYs, are definitely pointing to the fact that, you know, if people living with HIV are functional and live healthy lives, that the economic impact is reduced. And that's been shown right from chronic disease as well. So just to answer that question and add to what Darren has said, that there are studies that show that, and we did one where we looked at the impact of HIV on livelihoods, and it was very, very clear that HIV impacts livelihoods tremendously. And therefore, obviously, if we improve quality of life, if we improve function, people's livelihoods will be sustained and maintained, and that has economic impact. Thank you.
I would love to add to that as well, from what Helen said about livelihood, and it touches on something Andrew said earlier as well, which I think was really interesting in terms of support workers helping people who are living with HIV in the community. And I think you mentioned, Andrew, about all of the different things that can affect people living with HIV, which I think overlaps an awful lot some of the time with people living with mental health issues. And what happens is that a lot of those people, because of the episodic disability and the way it fluctuates, it stops people also getting into work, which I think there is probably a lot of research as well on the economic impact of people who can't work and who need to, you know, claim benefits, etc. So it impacts from that point of view, I think, economically as well. And what you were saying about someone who's a support worker, having an AHP who might have that holistic training around what Darren was saying in terms of function and physiotherapy, which is hugely important, and also that cognitive side of things in terms of what might help someone just get by with their day-to-day tasks to get up and go to work and contribute to the economy. So I definitely think there's an argument there as well to be had.
Absolutely. And Helen, I love your link to QALYs, because that's exactly what we do in some of the preventable diseases. And, you know, a big one for me being a respiratory therapist is COPD, and how we've translated that into therapy, into rehabilitation, pulmonary rehab, etc. And it's just a real nod to people who are listening to this podcast to think about the intersectionality as well. So HIV in relation to someone could also have COPD, or as Amy said, a mental health condition, or could be from LGBTQIA background, which means they may have additional barriers to accessing healthcare, or may have additional mental health, or may have additional stressors or stigma associated with that. So it's really just getting people to think about the bigger picture here, rather than it just being a virus, a disease, and just the concept of overlapping factors. So I never like to have the last word here, and I'm just going to come around to everyone individually just to ask it if they've got any final comments, anything we've missed out, anything you'd like to say, and also just signposting to anywhere they'd like to signpost to. So Mark, I'm going to come to you last to give you time to think and prepare. So Andrew, coming into you first, please.
Yeah, I mean, just honestly, thank you, Rachel, for, you know, organising this. And I think the first question was, why do we celebrate World AIDS Day and why is it important? And like we've all said, it's, you know, because we have a lot of work to be doing. So these platforms, you know, add a lot to that. I think you're all going to hate me as rehab professionals, but, you know, coming back to the economical approach, you know, we know that in all aspects of healthcare, money needs to be put in preventative healthcare and not getting to that rehabilitation stage. And that's why, you know, there are lots of campaigns. So please do look online, you know, from organisations with, I'm speaking again, sorry, with very UK focused, but we have likes of Terence Higgins Trust and, you know, U campaigns, trying to kind of reduce that stigma and increase, you know, access to PrEP, access to condoms, sexual education within schools, to try and reduce, you know, the number of diagnoses coming in throughout the years. And yeah, just on that, you know, tomorrow's a huge day. Get on Twitter. There's going to be loads on. A bit of a shameless plug. I've done a bit of a short video for OT Expert, who's going to be sharing lots of videos tomorrow. She's got 30 videos from people all around the world sharing some pretty important information on HIV. So just, yeah, get online and learn.
Completely agree, Andrew. Thank you. Saul, coming down to you.
Yeah, just thank you as well for inviting me, and lovely to see a couple of familiar faces and meet a couple of new people. And I think it's so important, you know, to just briefly add to the economic thing, you know, to work with people from different professions. Certainly in South Africa, we're not as fortunate, you know, to have an OT and a physio, and often you're the only rehab professional in a huge area. So we have to learn to task shift and teach others and share information like we're doing here. And COVID has actually given us opportunity here, you know, other than resilience, to be innovative. And, you know, I think we can learn a lot from each other, and then people with HIV will benefit from our enhanced knowledge. But yeah, happy World AIDS Day today for Mark and tomorrow for the rest of us.
Thank you, Saul. Amy.
I think I just want to say a huge thank you, being so new to the specialism, as I said, and being amongst such an amazing panel. Thank you for the opportunity to raise awareness about this fantastic day. And also a shameless plug, like Andrew, I've also done a video for OT Experts, so I'll also be glued to Twitter tomorrow to see all the exciting things that are happening. Thank you again.
Thanks, Amy. Helen.
Unmuting. Okay. I think the first thing I want to say is that while we celebrate World AIDS Day, we also remember all those that we have lost. Family, friends, colleagues, and some of us, you know, will know people personally. Some of us will know of other people. And as we remember them, I think we should honor them in the continued efforts that we take to drive HIV where it's needed most. And my parting shot is let's empower. I think everybody living with HIV has to be empowered to drive their own journey. And we are just there as instruments in that journey. And therefore, we must remember that on tomorrow. And of course, all the resources that you point to are just wonderful. And there are just so many out there. And the WHO resources are fantastic too. And yeah, so thank you for the opportunity. I wasn't sure what to expect. I've thoroughly enjoyed this evening. Thank you very much, everybody. And it's wonderful to collaborate with everybody directly and indirectly. And it's just so nice to be able to expand our network and our footprint. Thank you.
Well, and on that note, a massive thank you to you for dedicating a huge part of your life to all the research, the academia, the evidence, the guidance, so across the world. So you're definitely on my girl crush list for now, Helen, for sure. So thank you for that. Darren, I don't know how you can quite follow that, but...
Yeah, Helen, what have you done to me? God, can I have a girl crush too?
You're perfectly capable.
I really want to echo some of what Helen said there in terms of remembering the people that have been lost to advanced HIV and AIDS-related complications. There's 36 million people living with HIV globally that have died. And I think it's incredibly important that we do honour and remember those people. And that is an incredibly important part of World AIDS Day, adjacent to celebrating the successes of effective treatments, U equals U, and people living normal life expectancies, but then also recognizing those challenges. And I think one of the themes this year of World AIDS Day is focusing our attention and our targets on those key and vulnerable populations. And I want to really emphasize amongst those key and vulnerable populations are people living with disabilities. So first of all, people living with disabilities are shown to be at higher risk of HIV acquisition, but we also know the high prevalence of disability experienced by people living with HIV. So we need to ensure that we have disability inclusive responses to all of the responses to HIV and AIDS globally. And that means the greater involvement and meaningful engagement of people living with HIV and disability in those responses.
Thank you, Darren. And Mark, over to you. It's now 7:15 in the morning. So it's a little bit later, but any final thoughts from you?
Yeah, again, just a big thank you for hosting such an amazing morning/evening for everyone else, and to be on a panel with such amazing people is a real honor. I think going into World AIDS Day this year, I think that we're remembering all of the people that have come before us, all of the knowledge, all of the expertise, all of the lived experience that people have fought for and people have dedicated so much of their lives to. I think, the global fight to end HIV is getting closer and closer. And I think it's really important that we just stay connected and tight-knit with our local communities so that we understand at a ground level what's going on and what the unique needs and challenges are in our local communities. Because I think that's probably the most important thing, as much as everything else that's going on around the world. Connecting with people that are around you and understanding their needs, I think, is really, really important.
Thank you so much. And I'm aware it's very late now for our colleagues in the other parts of the world as well. So just a massive thanks to the panel. Now, we're never normally asked for any kind of donations or any kind of charity events. These are completely free and completely accessible across the world. But maybe if you can spare that price of a coffee or that pint of lager or that glass of Chardonnay, maybe just think about just giving a little donation to one of the HIV or AIDS charities across the world, because every little does help. We will post some links underneath this YouTube channel, as we've mentioned, as well as some potential charities if you do feel the need. But once again, thanks so much for listening. Take care and happy World AIDS Day 2020, everyone.